Thank you for being here. So we are going to start an IC on optic nerve. I'm Sushma Tejwani, a glaucoma specialist, and this is Dr. Jyoti Matalia, a neuro-ophthalmologist. So both of us will take you through the various intricacies of optic nerve evaluation, how to look for whether it is a glaucoma issue or a neuro-ophthalmology issue. So we have different talks. Maybe there is an overlap which all of you may come across in your clinical situation. So I'll first talk about optic nerve evaluation in glaucoma, and then we go ahead with the unilateral and bilateral disc edema. Right, so let's look at how do we evaluate an optic nerve, what is DDLS, that is disc damage likelihood scales, and what masquerades we look at. Definitely need intraocular pressure and the disc changes and field effect in addition to gonioscopy. But why optic disc is most important, because this is something which is very specific in diagnosis. The intraocular pressure and visual fields can lack sensitivity, there can be an overlap, and the anatomical changes definitely happen earlier than the functional changes, and that's how we need to look at it. So we definitely have to learn how to carefully examine a disc and understand what is the proper examination technique, so that we can understand what is the normal appearance of the disc in NFL, what are the changes in early or pre-perimetric glaucoma. So we should be able to diagnose glaucoma like how on the upper disc that you can see there is a loss of inferior rim rather than the lower stage, because we don't want, this is that the lower diagram that you see is very evident advanced glaucoma. So the best way to look at the optic nerve is not really the indirect ophthalmoscope or direct ophthalmoscope, because direct ophthalmoscope does not give you a stereoscopic view, and the indirect ophthalmoscope gives you a very less magnification. How to play the video? Okay. Right, so this is how we actually do the optic nerve evaluation on a slit lamp biomicroscopy. So it's important to understand how do we do it. You position the patient properly on the slit lamp, taking care that the line matches the nerve, the center of the cornea, and with the undilated pupil on a retroillumination, you go close to the cornea and then focus on the cornea and then interpose the lens and try to pull joysticks toward you, and that is what you see. You can see in the bottom square that this is how the optic nerve looks like. So all of us as glaucoma people should look at the undilated disc before we do the gonioscopy, so that we have an idea of how the optic nerve looks like. And when eventually after dilation, it is important to look at the optic nerve too, because the Rnfl defects or a small disc hemorrhage is something that you can miss if you have not dilated the pupil and evaluated the optic nerve. Now, so we know this is how we look at, and now I will be taking you through the different features in glaucoma, and we will be talking about each one of these topics. So these are the different list of optic disc changes that you see in glaucoma, that is loss of ISNT pattern, disc hemorrhage, and different effects. I'm not going to read through that. The basic thing that I want you to understand is there are certain objective signs, that means say presence or absence of a disc hemorrhage or presence of a Rnfl defect or notch, etc. And there are certain subjective signs where the CD ratio is this much, or there is asymmetry and things like that. So objective signs are something that we cannot ignore, because they are very specific of glaucoma. Subjective signs can vary between you and me, or two colleagues where we are examining. So we have to be sure and substantiate them with the various investigations. Now coming to the optic disc size, the variability in the optic disc size varies as high as say 0.8 millimeter square to 6 millimeter square, and that is independent of any other refractive errors and stuff. So you can have a small disc with abnormal cup being 0.5 and a large disc with 0.7, 0.8 cup being normal. The size increases with high myopia and lesser with the high hyperopia, and there is a ethnic variation, racial variation that we need to keep in mind. There are certain disorders that happen in smaller discs more commonly and the larger discs more commonly, that are listed here. So is it important to do the optic disc size measurement? Well, not in all cases, but where you find that there is an asymmetry between the two eyes, or if you want to really look at, then you can use a slit lamp biomicroscope with a thin slit so that you avoid the spillover, and you can use any of the lenses and have the multiplication factor. However, if you keep using the same lens throughout, you can actually have an idea of whether it is small, medium or large disc, which is important to understand when we talk about the CD ratio and all. So coming to the CD ratio, this is the most common thing that we document when we see that CD is 0.5, CD is 0.3. That is why, because this is something which you can follow up over a period of time. So what is the disc margin? That is the defined by the inner edge of the white scleral ring through which the nerve fibers pass or ganglion cell pass. The cup is the level where the neuroretinal rim steepens. So that is the CD ratio, and what we talk about always is a vertical CD ratio, not the horizontal CD ratio. This is C by D. So CD ratio can be normal as low as 0 and as high as 0.87. So we need to understand when we are talking about CD ratio that what other things we need to look at. Generally speaking, more than 0.6 is considered abnormal or doubtful of glaucoma, because that is seen in less than 5% of the patients. And the 0.2 asymmetry between the two eyes is also something which is seen in less than 5% of the normals. So we have to be careful when we have this kind of CD ratio. So what is the importance of this CD ratio? Well, we know if the disc size is bigger, the number of axons that has to pass through that canal is the same. So cup is something which is a leftover space. So if you have a larger disc, you are bound to have a larger cup. If you have a smaller disc, you're bound to have a smaller cup. So that is why CDR does not mean anything unless we specify whether it is a smaller disc, medium-sized disc or a large disc. So that is how CD ratio becomes important. So more importantly, over a period of time, when you see the higher CD ratio, that suggests progression. If you see asymmetry between the two eyes, that gives you an important clue. And in general, high CD ratio gives you a suspicion of glaucoma so that you can evaluate more carefully. So this is the progression. Upper one is the progression over a period of time, and the lower one is the right and left asymmetry. So this clinical example that you can see, the right eye on the top and the left eye at the bottom, CD is much different, 0.3 up and 0.6 down. And if you look at the visual fields there, you can see the superior defect in the left eye, which clearly tells you that that is glaucomatous. Coming to the neuroretinal rim, well, this is the most important part, because that is where the ganglion cells lie, and that is what we are interested in. We don't want the loss of NFL or neuroretinal rim, so that has to be evaluated clearly, carefully. So there is a ISNT rule, I'm sure all of you are aware, which says that inferior rim is bigger than the superior, and then the nasal and the temporal, so you have to keep that in mind. This particular rule is less marked in larger disc, because the nerve fiber layer or the neuroretinal rim is more evenly distributed, because the ganglion cell axons pass towards the periphery. So this rule applies largely to the medium-sized disc. The smaller disc and larger disc, you can ignore that. Coming to the shape of the neuroretinal rim. Now if you take a cut section of the optic nerve, the first thing that you see, the normal, if you see a cut section, you will see a horizontal cut there, the neuroretinal rim. This is how the shape of the neuroretinal rim should be. When it bends like that, in the second, I'm sorry, I'm not able to see my mouse on my screen. Yeah. So this is where it becomes sloping. Okay, so that is what is called as saucerization of the disc. And in the C diagram that you see, there is a loss of differentiation between the neuroretinal rim and the cup, and that is called as sloping. And when you have the excavation, that is when you see a notch. These are the diagrams, and this are the real clinical pictures of the same discs that I demonstrated to you. So when we see in stereoscopic view, you can actually see which category it fits into. So this is a clinical example of a large disc where you see the CD ratio being very high, but if you notice, inferior rim is less than superior rim, so we are having a loss or reversal of the ISNT rule, and that's what is shown on the perimetry also. You see a superior defect corresponding to the thin inferior rim. So in this particular example, there was loss of ISNT, there was increase in the CD ratio, that's how we picked up glaucoma. If you see a notch, like how you saw the excavation in the fourth diagram, you can see a corresponding field defect there. Disc hemorrhage is again a very specific objective sign. Presence of disc hemorrhage definitely means glaucoma because it is seen in less than 1% of the normals. However, absence of disc hemorrhage does not mean much because it is seen only in, say, around 5% of the glaucoma patients, because it does not last long. It lasts for a few weeks and eventually it translates into a nerve fiber layer defect. So even when you are seeing the patient during that time when the disc hemorrhage happens, then only you will be able to pick it up. So it has a low sensitivity but very, very specific for glaucoma. Like this example, you can see a small disc hemorrhage and you can see a corresponding field defect also. Circumlinear vessels, another important thing that you can pay attention to. Well, all of us do not have circumlinear vessels. Only 50% of us have circumlinear vessels, and they look like this. They exit from the neuroretinal rim and exit at the macula. They follow the neuroretinal rim. So people who have circumlinear vessels, in them, when there is a loss of neuroretinal rim, which is called bearing of neuroretinal rim, that is suggestive of glaucoma. Again, one of the very specific signs of glaucoma, but mind you, all of us do not have circumlinear vessels, so we should look for it. Another very important sign for glaucoma or early glaucoma is a localized Nfl defect. Now these are the wedge-shaped defects that you see coming from the optic nerve and then fanning out towards the temporal raphe. They are dark areas where the nerve fiber layer is gone, and they are very, very specific for glaucoma. You can see an example where here you can see superior and inferior Nfl defects and the corresponding visual field defect, superior and inferior, as you can see. The best way to examine an Rnfl defect is green light or red-free photograph or a red-free filter when you're seeing on slit lamp, because they become prominent like that. Well, there are ways to check it in terms of imaging techniques, OCT, HRT or GDX, but here we are talking about the clinical evaluation. So a red-free diagram makes it much more prominent. So this is how a normal NFL looks like. The normal nerve fiber layer obscures the normal vessels. You see very limited slit or groove-like defects, which are narrower than the retinal vessels. When you look at the localized Rnfl defects, they are actually large, dark wedges, which are larger than vessels. They are narrower at the disc margin and then become broad. When there is a generalized NFL defect, you see the loss of that dark, bright pattern which you see in the normal NFL. So this can happen in advanced glaucoma, AION, and any situation where there is a generalized NFL loss. Peripapillary atrophy is something which is a corroboratory sign, which is not a definite sign, but that helps a lot if you look at the central beta zone and peripheral alpha zone. In glaucoma, we will be talking about mainly the beta zone, because alpha zone is seen in almost 95% of normal people also and is related to myopia and age as well. So beta zone is more important and is larger in high myopia or myopic glaucoma. The problems with myopia and glaucoma is that sometimes it is hard to see even the disc margin, so it's very difficult to assess the neuroretinal rim, to assess the CD ratios. So in these situations, we largely have to depend on the functional aspect or the perimetry, because it becomes difficult to judge. Just to give you an example where the perimetry can also give you a doubt and you have to be careful. So this is a patient who has myopia, and you can see the field defect in the left eye, but be careful, this is not the glaucoma, this is the enlargement of blind spot which is related to the myopia and peripapillary atrophy. Why I do say that peripapillary atrophy is a corroboratory sign and not a definite sign. Now this is a classical example of that disc. If you see the PPCRA or atrophy is much more inferior, but if you look at the disc, the neuroretinal rim is much thinner, superior. And you see a field defect which is corresponding to that superior thinning and not to the peripapillary chorioretinal atrophy. So what does that mean? That means we should not get biased only by the large peripapillary atrophy in one direction. We should look at the neuroretinal rim in terms of glaucoma. Now coming to disc damage likelihood scale, I'm sure all of you are aware of this thing. Just to give you a brief of what things it takes into account, what we all went through during this presentation is something, it is a summary of that almost. That is the disc size measurement it takes into account. It takes into account the neuroretinal rim thickness. So it looks at radial width of the neuroretinal rim at its thinnest point. And that is the rim disc ratio that we look at. It does not take into account CD ratio. It takes into account rim disc ratio at a thinnest point. Okay? And when there is no rim, it is considered to be a 0. And it also takes into account that what is the circumferential extent of the rim absence. What we need to be cautious about it does not tell you about the sloping or the absence of, if there's a total absence of the rim, it does not take into account. So the number 1, 2, 4 is considered disc at risk. 5, 6, 7 is considered glaucomatous damage, and 7, 8, 9 is considered glaucoma disability. Just an example, this is the nerve that you look at. Now look at, this is a large disc. It's the thinnest rim width is there, the blue line that you can see. And if you look at disc diameter in that axis, you see the rim disc ratio say around 0.15. So this is where it fits into the DLS stage 3. So what is that? That is supposed to be disc at risk. Another example, you can clearly see a notch there. This is a medium-sized disc, so no rim at that place. Circumferential extent of rim absence is around say 45 degrees. And this fits into DDLS stage 6. So this is the glaucomatous damage. And this is an advanced damage. You can make out no rim, almost 240 degrees. There is circumferential extent of rim absence. So this fits into stage 9. So this is a glaucomatous disability. So that is how DDLS helps, but believe me, the best way to document is disc photographs. And the next best is the hand drawing that you make in your chart about how much is the absence of the rim, where is the slope, where is the notch. So that is the best way to document. There can be pseudo-glaucomatous discs, which I will not talk much about. Dr. Jyoti will take you through. And always remember that we have to look for glaucomatous changes in all the discs. We have to look for Rnfl defects in all the discs. We have to look for disc hemorrhages, and we should consider each myope as a glaucomatous disc so as to evaluate them clearly. So these are Jost-Jonas rules. Just to give you a clinical example, this is a 41-year-old male, and you can see an NFL defect down there. Everything else was normal, not suggestive of glaucoma anywhere. You do a visual field defect, there is nothing, but when you do an OCT, you can see a corresponding thinning there. So in this situation, it is the only careful disc evaluation that could make us diagnose glaucoma and treat this patient, because when we did DVT, the pressures were high and we started on treatment. And later on, when we did the blue on yellow field, it actually showed defect in that part. I think that is missing here. Another situation where there's a patient who was having glaucoma and on glaucoma treatment, and this is the field that he came along with. But when we looked at the optic nerve, it looked perfectly healthy, and you could substantiate it by OCT. So unless you have a careful disc evaluation and you treat only on the basis of perimetry, that's not going to work. So this was just a clover leaf defect and unreliable fields. So unless you do a clinical evaluation, you can actually have an unnecessary treatment for any patient. So fields could be deceptive, but not the disc evaluation. I think I will skip this part.
You can take it, Sushma. You can take the case.
Is it? Okay. So this is a classical example where everything correlates. We don't get such nice cases every time, but here you can see a 30-year-old male presenting with 18 pressures. You had superior rim thinning and superior notch in both the cases, and you could see the visual field defect there, both inferior defects there, and OCT again corresponding. So everything matched, POG on treatment. This is the simplest way to diagnose, but then there are crucial situations, as I showed you in the earlier cases, where the clinical skills help, and we need to definitely look at it more carefully. So always identify the clinical signs, and interpretation of the various tests should be done in light of the clinical signs, and connecting the dots is most important before you label a patient and start treatment. Thank you for your kind attention. Yeah, you can take over, Jyoti. Meanwhile, if anybody has any questions till the time she's loading the presentation.
How do you suspect glaucoma suspect?
Yeah, so if you have a disc suspicion, like how I showed a case which had an NFL defect, till the time you reach to the diagnosis, that is a glaucoma suspect. So you need to evaluate further whether there is a perimetry change or an OCT change or clinically it fits into, then only you will make a diagnosis of normal or glaucoma. So when you see a glaucoma suspect, it can be related to high intraocular pressure, a disc change, or a field change. So if you see any one of them, that patient would become a suspect. And then you evaluate and connect the dots to be able to make a diagnosis.
New patients IoT if you find higher, more than 20, and rest things are normal. Everything is shows. Still, you will start treatment.
No, not at all. You can ignore that pressure and can follow up. It may be due to high pachy, or just a single high reading may not be important. So you can just follow up. That patient should not be started on treatment. At max, that patient can be ocular hypertension, which again does not require treatment. If you're sure the discs are normal, fields are normal, no treatment.
How up we can keep a patient under observation?
How high IOP? Even up to 28-30, you can keep it as under observation if the discs and fields are absolutely normal.
It should be repeated every 3 months, or
Yes, if the pressures are high, say 28-29 range, every 3 months you can repeat. But if the pressures are say like 22, I would call a patient in 6 months' time if other things are fine.
very important question, don't mind. But if patient IoT is high, suppose patient comes to one person, if he goes to another person, he says, oh, your IoT is very high, 28, you are the first person has missed glaucoma. And then he starts treatment and patient comes to 20. Does it has got any medical legal importance?
No, sir. I think in that context, I would not be much worried about glaucoma. There are many situations like that. You may tell a patient that there is no cataract, and your colleague may say there is cataract, needs immediate surgery. So those kind of implications can be anywhere, and anybody can be right and wrong. But in terms of treating a patient for purely the clinical cause, I think we should not be treating the patient.
I think we can take questions later
At
at
the
the
end,
start.
yeah.
Presentation. No, not for you. I'm telling for the next question. Okay. No. I said the next one we can take later.
Yeah.
So good afternoon all. I'm Dr. Jyoti Matalia, and I'm going to be talking on disc edema. We just heard how to evaluate a cupped disc. Now let's see what happens when the disc is elevated. Now, two important questions. When you see a swollen disc, you need to first rule out whether it's physiological, and most importantly, whether it's life or visual threatening. And hence, every disc should be documented, monitored, and followed up. So how would you evaluate? Yes, disc edema, look if there's a visual loss. If none, then we are looking at a pseudo or early papilloedema of the disc, diabetic papillopathy, or a CRVO. So let's look at this patient who came with vision of 6/6, normal pupils, and you see a disc like this. So is this edema? Let's understand and evaluate the disc. Elevation is confined to it. Disc vasculature is visible at the margins, no venous congestion, sharp peripapillary nerve fiber layer reflex, and crescentic circumpapillary light reflex with no exudates. So this is pseudoedema. And what you need to do, a B scan, which will show this calcific area, confirmed on CT scan. Also, if you have an autofluorescence, will show these calcific deposits, and this disc edema is actually disc drusen. So we confirm that this is a pseudopapilloedema. Then what is a true disc edema? Elevation extending into the peripapillary retina as shown, graying and mudding of the peripapillary nerve fiber layer, and obscuration of the vessels at the disc. This is true disc edema. So when you have something like this, let's look at chronic papillopathy. It's seen in patients with IDDM or NIDDM. Classically, vision be about 6/15, but no NVDs. There is edema. The best part is vision comes back to normal, and hence, over time, you come to know that this is a diabetic papillopathy. Classical CRVO will you see, but you will have other features of retinal as seen here. You need to evaluate and treat the cause of thrombosis and long-term risk of neovascular glaucoma, which is important. Now let's go to the next aspect. If you have a disc edema with acute visual loss, we are looking at major options of optic neuritis, ischemic optic neuropathy, and Leber's hereditary optic neuropathy. So let's look at this case. 15-year-old girl from Bangalore presented with 3 days duration, sudden onset pain in the left eye, associated pain on eye movement, very, very important, with decreased left eye vision, no history of any recent fever or complaints in the past. Ocular examination showed decreased vision, abnormal color vision and contrast, and RAPD, which is relative afferent pupillary defect. Very, very important. That's a pathognomic of an optic nerve problem. Look, as you switch the light from the right eye to the left eye, the pupil appears to dilate. That's because of the decreased pupillomotor impulse due to an optic neuritis in this case. Now you look at the disc, right eye is perfectly normal with a normal field, but if you look at the left eye, there is mudding around the nerve fiber layer around the optic disc. The nerve fiber layer you can see here, it's affected. So this with a field test showing an inferior altitudinal defect, classically telling you there's a left eye disc edema. So in a young female with sudden onset of loss of vision, pain on eye movements, classical of optic neuritis, loss of contrast, color, because first is the contrast to get affected, then the color vision, RAPD, and an inferior altitudinal defect, we are actually looking at optic neuritis. So this is very, very classical. When you look at loss of color vision, they will tell you the color saturation has gone down. So a red will look less red than what you normally see. Again, RAPD, very, very important. If you pick up an RAPD in a normal looking disc, you know it's an optic nerve. You need to evaluate from neuro-ophthalm. So this is left eye optic neuritis. When you get, how do you diagnose? A very, very thorough history and an appropriate examination. So what is neuritis? Inflammation of the optic nerve head, mostly associated with multiple sclerosis, but in Indian scenario, look for syphilis, sarcoid, TB, etc. also to be seen, which is important. So after this, when you are suspecting optic neuritis, look at MR imaging of the brain with contrast. That's important. Like this is the T2 weighted image. You will see the contrast enhancement happening on the optic nerve heads, which is classical. And the T2 flare image, you will see this ovoid, periventricular, perpendicular to ventricles, these classical lesions, which tell you that this could be related to MS. These are hyperintense lesions. So how would you investigate? Baseline MRI scan. If normal, just sequential follow-up. But if there are presence of 2 typical white matter lesions or more, we have to treat with IVMP. Now, IVMP is on the basis of ONTD trial, but remember, this is only to fasten the recovery. It does not do anything to the outcome. Even if you don't give it, eventually the patient is going to recover, but it will do it faster. And if you have this particular criteria, you are suggesting it of MS. There are other tests to rule out the other causes. LP has no benefit unless you're looking for papilloedema, where you look for the opening pressure to diagnose IIH. And for ischemia, look at other risk factors. So if you see, this is the classical defects. These are the ovoid lesions seeing perpendicular to the ventricle, called as Dawson's finger. So this child had demyelinating optic neuritis with multiple sclerosis. Now you could also have demyelinating optic neuritis simultaneously or sequentially. If you have something like this, where patient comes to you in time of edema, it's fine. But what if the optic atrophy is already set in? So you have an optic atrophy in one eye, and the other eye shows a disc edema. You are looking at 2 types of demyelinating optic neuritis. One is neuromyelitis optica or NMO. The other is MOG IgG associated disorder. So what is the difference? The NMO is a bilateral, simultaneous or sequential relapsing optic neuritis with affection of more than 3 segments, that is of the transverse myelitis, as you can see here. It is classically associated with refractory hiccups and vomiting, and alpha-chlorine 4 antibody marker is very, very positive. You need to treat with IV corticosteroids and rituximab, but remember the recovery is poor. Unlike MOG IgG, this we have initially called as chronic relapsing inflammatory optic neuritis, bilaterally simultaneous peripapillary hemorrhage, but interestingly on MRI, the perinumeral and the peribulbar fat enhancement is seen. The MOG IgG cell-based assay is positive, and treatment remains the same, but excellent recovery. They do well, but you have to slowly taper the steroids because they are directly related to the steroid dose. Then how do you differentiate the next cause of acute visual loss? Ischemic optic neuropathy versus optic neuritis. So let's look at it. Ischemia occurs in older age, whereas demyelinating in younger. You have classical pale disc in ischemia. You would have sectoral disc edema as shown here. The superior part is paler than inferiorly. And you will have hemorrhages which are seen in ischemic cause. Association, therefore, in ischemia is vascular disease, whereas demyelinating is multiple sclerosis. And treatment-wise is excellent with demyelinating. So let's look at this case, a 60-year-old known case of diabetes for 15 years, painless loss of central vision. You can see right eye vision is less and has right eye RAPD. So now, as I said, you have a sectoral edema. See this? This is affected. At that time, what is important is looking at the other eye. Other eye, if you see the disc, there is hardly any cup. When you have something like this, there's an increased risk that this eye also will develop a NAION. So this first diagnosis is NAION, that is non-arteritic ischemic optic neuropathy with sectoral pallor and left eye disc at risk. So this is classical disc at risk. Watch this patient because this patient can have a problem in the other eye and treat the ischemic risk factors. And this case, as you said, the sectoral pallor is directly associated with the inferior altitudinal defect. So when I say disc at risk, what ischemic risk factors you treat? First, BP, check every patient with a disc edema in your OPD while checking the blood pressure and creatinine, because hypertension is in more than 34 to 50%. You have to do diabetic workup. CBCS or CRP for anemia, lipid profile for hypercholesterolemia, serum homocysteine in young patients, look at other prothrombotic factors. Carotid Doppler is a must for IHD and thromboembolic phenomena. So now going to the third part of the disc edema, insidious visual loss, which would be compressive optic neuropathy or infiltrative. When we see compressive, we're looking at optic nerve sheath hemangioma, and these classical optociliary shunts is what you see. If you see them, you can expect a lesion behind, or an intraconal tumor. And classically, other conditions like leukemia and lymphoma, where you will have sudden onset, so a good history about his past will tell you what the problem is. Now let's come to the next aspect, bilateral disc edema. Now when you see a disc like this, we are worried, is this papilloedema or is it a bilateral optic neuropathy? And what we can differentiate by doing a vision loss, which is very important. So bilateral disc edema, no vision loss. Yes, we've seen pseudo disc edema, but you could also have early papilloedema, hypertensive retinopathy, and hyperviscosity. On the other hand, let's see, this is a patient with early papilloedema. Vision was perfectly okay, but you can see this indistinct elevation seen all around the optic nerve head. Or hypertensive retinopathy, you can see classical history of hypertension, narrowing at vessels. But malignant hypertension, if you see with grade 4, you will have this classical disc edema. Hence, every patient of disc edema, measure the BP in your OPD, important. Then, coming to the next aspect, visual loss in bilateral disc edema. These are multiple, few I've already described, but I'll talk primarily on papilloedema and inflammatory causes. So what is papilloedema? A patient with 34-year-old obese, transient visual obscuration is a very, very important history that you take. Other history is tinnitus. If they have these, you are going to think in terms of papilloedema. Vision, as you say, in initial stages is perfectly okay. So you just see hyperemia of the disc, elevation is indistinct, and absence of the cup, and the other venous engorgement. So this is established papilloedema. Now this differentiates you from an optic neuritis where vision is lost. So vision in papilloedema is lost only in the final stages. This patient had an idiopathic intracranial hypertension. Initially, the fields are perfectly okay, but you start seeing the inferonasal step. This is the early sign of glacial constriction can there happen. Now, as you said previously, I showed USG B scan is very important because it not only rules out a pseudodisc edema by looking at the drusen, but it classically picks up this crescent if you see around the disc. This is the SAF, the subarachnoid fluid of the raised ICP, which is transmitted around the optic nerve, which will tell you. And if it's more than 3.5 millimeters, definitely this disc is edematous. And why? Because you know that as the CSF is produced by the lateral ventricles, third ventricle and fourth ventricle goes in the subarachnoid space, and this space is right around your optic nerve head, and this is what you pick up in your B scan. Then comes the chronic papilloedema. You see disc is highly elevated. You see the optociliary shunts are also seen, and there are deposits like corpora amelaicea, which are seen along with Patton's lines. So this is again the same sign. This is indicating of chronic papilloedema. Now the inferonasal step is gradually going into constriction, and the patient has started to lose vision. In atrophic, if you see, the disc starts appearing to flatten. You will see pallor setting in as seen here, and the Patton's lines. Don't get misjudged that the disc is flattening. Actually, it's failing. The patient has started to lose vision. And if you look at the visual fields, eventually it's going into complete constriction, and he will eventually go blind. So at this stage, it's important to treat. So how do you go about? Basically, investigate. You do the B scan to confirm there is SAF. That is a cause, and so you can treat accordingly. Imaging of OCT to know how much it's progressed. Visual fields. Non-ocular, record the BP, neurological evaluation and neuroimaging. CSF opening pressure will tell you whether this patient has papilloedema. Anything more than 250 millimeters water will definitely tell you this is papilloedema and you need to treat. You have to collaborate with a neurologist and they will treat accordingly. So how do you treat these patients? You would treat them medically or surgically. First, address the cause. If there's any tumor in the brain, you need to remove it because of any SOL. Then refer to the neurologist. What will be the medical treatment in IIH? That's idiopathic intracranial hypertension, oral acetozolamides, salt-restricted diet, and weight loss. Weight loss of 15% is a must. In COVID pandemic, we've seen being at home, people have increased weight over 3 months and have developed IIH. It has increased a lot. CVTs, cerebral venous sinus thrombosis, identify the precipitating factors and treat with oral anticoagulants. Surgically, yes, reserved for conditions like if there's a mask or hemorrhage, you need to do neurosurgical intervention. If there is IIH, headache is the primary cause, you need to do the VP shunt or LP shunt or serial lumbar punctures to reduce the pressure. That will reduce the headache. But if his vision is threatened, like the previous cases I showed you where the fields are significantly constricted, optic nerve sheath decompression with or without shunt should be be done. Remember? 1 minute, something is popped up here. Remember, ONSD is something we as ophthalmologists can do, and we are the only ones in salvage vision, because in IIH, the only and serious complication that a patient can have is completely loss of vision. They can go completely blind. They don't get any other neurosurgical problem. So we should know how to do it. So a quick way how to do, 270 degrees peritomy has to be done. Hook the medial rectus muscle. After you do it, pass sutures through it, isolate it, and then take the baseball stitch. This moves the eye completely laterally. After you move laterally, you look at the optic nerve head. You can see here, this is the elevated optic nerve head with the translucent optic nerve head sheath. So this surgery is a medial transconjunctival approach. With a bent keratome, you go into a blood-free area, as you can see, and release the pressure. Note the gush of fluid. This fluid is completely the raised CSF, which is around it. Take a part of it outside, that's the optic nerve sheath fenestration, and break the attachments around. This is followed by a closure by getting the muscle back to its position and completely close the conjunctiva. So you can see in this pre-operative patient who had a vision of 636 in both eyes, with significantly constricted fields, underwent ONSD, and post-operatively you see flat disc and 6x6, and the vision fields completely comes back to normal. And that's the great part of doing an ONSD. You can get back the vision and salvage it as an ophthalmologist. Now, a quick other question of patient with bilateral optic disc edema, a 33-year-old referred by a neurologist to rule out papilloedema, had tinnitus. These patients also can have tinnitus. What interestingly you should note is 612 vision, and there is vitreous cells. So when you look at the disc edema is there, but carefully look at the retina as well. You can see on red free. So red free is a very, very important tool for us to pick up features around the optic disc, and you will see multiple errors of NSDs, that is non-serious detachments, you can see, and PEDs. So important red-free photography, vitreous evaluation, and look beyond the disc. So an OCD showed that there are multiple NSD lesions around it. This patient had VKH. So you need to look not just as a neuro-ophthalmologist at the disc, look at the whole patient, all the aspects of the eye to pick up this. So to summarize, when you have a patient with bilateral disc edema, complete history and a thorough examination is a must. You need to appropriate tests like B-scan, FFA, OCT, BP, blood tests, including CBCSR for identifying the optic neuropathy. You need to do, once optic neuropathy ruled out, do a thorough neuro and neuro-ophthalmological evaluation, that is CT, MRI, MRV, MRA, LP, and CSF analysis. You need to rule out papilloedema in all cases. That's a must. Good coordination with the neurologist and neurosurgery is a must. Thank you.
We can take a question till the time we are shifting.
So now the next topic is going to be evaluation in terms of fields, OCTs, B-scan, whatever we can do to isolate optic nerve problems. So I can take questions in the meantime. Yeah. Intracranial hypertension. No, I'll just correct. Benign intracranial hypertension was initially called, it's no longer benign. Now it is either called a pseudo-tumor cerebral syndromes or IIH.
I have seen neurologists, not to comment on anybody, they give very low dose, half OD or this thing. Patient is uncomfortable, and when we increase the dose, half BD or 1 BD, 1 BD is too much, but 1 OD, 1.5 OD, then patient is quite comfortable. And other treatment they continue it, but why so? And how long we should give Diamox? And they are, when we talk to them, they say that Diamox will damage your kidney, means patient's kidney.
Okay, so this is a good.
But and somebody expert from AIOS, he told ki don't worry for Diamox. Diamox will not damage kidney.
No, that's true. Diamox would damage kidney, but that's also true that neurologists actually don't give much. They start. So ideally, how do you treat patients with IIH? Start with a low dose, and you can increase as high as 4 grams per day. So you can give 4 grams per day. But
how much? That is 250 ka tablet aata hai. How much means?
No, this is how neurologists do give, but you can. But sometimes patients don't tolerate. The amount that can be tolerated is 2 grams per day. You start with about 250 OD and go gradually over. What you need to do is each time as you're increasing the dose, you need to monitor by an ophthalmologist. Now, initially when I started my practice, I had issues with a neurologist, but now that I'm in a health city and I have a rapport with them, they start the Diamox and reduce only when I decide. So ideally, treatment of IIH has to be guided by the ophthalmologist to the neurologist. neurologist. Because what I said, eventually the patient is going to go blind, which is not going to affect them. We are the ones who are going to suffer. So we need to keep on telling the neurologist that, look here, the thing that they're going to lose is vision, so we need to have a good collaboration with them. In fact, the other thing I've noticed is they keep on giving steroids, which is not even indicated. So ideally, they have to gradually increase the dose. Yes, we have to monitor. You need to give supplements with KCL and all so that they don't get side effects of Dimox. But the entire thing can go over about 4 to 6 months. Once you see that the disc edema is resolving, you start tapering it off gradually. Most importantly, put them on weight loss management, which is very, very important. In fact, cutting down the weight can in fact put them on maintenance. That is one of the best things that you can do.
And second thing, I just want, before, just one question. Before we get investigated all, can we start Dimox because patient wants some relief?
No, you have to confirm the diagnosis either by doing an LP to know the opening pressure or B scan to know there's fluid behind. 2 ways to confirm, only then you can label it as IOS.
Thank you.
Okay.
I work in a multi-speciality hospital and we do a lot of transplants and stuff, and we are on regular touch with the nephrologists and neurologists on patients. It's a misconception between ophthalmologists that Dimox damages the kidney. It damages the kidney only if the patients are on renal transplant or are severe diabetes, because it can cause acidosis because of bicarbonate release. In healthy human beings, the kind of dosage we give, ophthalmologists maximum gives 250 milligrams 3 times a day to control IOP and other stuff. It's very, very safe, because some of my patients who are bad glaucoma, operated, shunts, and they have to be on Dimox for a very long time. The nephrologists, and these are the top nephrologists of India, have given a release check for Dimox, and they say that you can do probably a 3-month renal function test, because sometimes patients will have to be on Dimox for very, very long time.
Okay.
Sorry, I have a question, please.
I think we take, take
yeah.
it later because we have 4 more talks to go.
All right.
Thank you,
So let's look at how do we look at the NFL layer and scotomas. I'll be a little faster here so that we can cover the whole thing. So we know we have to correlate structure and function, and we have to look at both the things when we are diagnosing glaucoma, and that's the recommendation. So let's look at how do we look at structure first. Well, we have gone through from time domain to spectral domain to now sweat source, OCT. What you need to understand that whatever you have, the diagnostic accuracy of each of them is as good when you have to diagnose an early or pre-perimetric glaucoma. So you really don't have to worry which OCT you have. You can see different printouts as they see in different types of machine, but every printout gives us some basic things which I will take you through one by one. So you have to look at what is the patient identity, image quality, centration, etc. So you get color-coded thickness maps, deviation maps, you get a red-free image, you get average thicknesses and Rnfl thicknesses values in terms of Tisnet graphs and clock hours, and then the ONH parameters. We'll go through one by one, don't worry. So coming to Rnfl maps first. So when you look at the centration and the things are all right, you look at the thickness maps first. So when the Rnfl thicknesses are more, you see the hotter colors there as you see in the upper diagram, and the thinner areas are represented by cooler colors like blue and green, like how you see in a glaucoma patient in the lower diagram. Then you see the deviation maps, which tells you the deviation from the age-related normals. So machine would have compared with the normative database, and it will give you yellow or red flag signs where the nerve fiber layer is abnormal, and you can know the intensity of the abnormality by the color. So we do look at the correlation between the two. So if you have a thinner NFL, you will have red flag signs there. Now looking at the Rnfl thickness analysis, it gives you a quantitative measurement in terms of Tisnet graph. So if you look at that black line, this is the patient's Rnfl thickness in a Tisnet graph. The green area shows you 95% of the normals. The red area shows you the 1% of the normals. And in clock hours terms also, you get this color-coded map so as to understand whether it is normal, borderline or abnormal. And it also gives you an inter-eye symmetry analysis so as to understand how the two eyes differ amongst each other, so as to understand which one is worse or which one is glaucoma. The second part tells you about the optic nerve head analysis. Now this scans determine the anterior surface of the Rnfl and the RPE so that it can give you the rim area, it can give you the nerve width at the disc, you can have cup diameter, you can have disc diameter, and absolutely quantitative analysis of the optic nerve head so that you can compare. The ganglion cell complex is something that we have started looking at lately for glaucoma. That is a nerve fiber layer, ganglion cell layer, and the inner plexiform layer, where you look at the macula. Now these are also seen as thickness maps in terms of color-coded maps. The middle one is the deviation map as compared to the normative database, and the third one is a significance map that tells you how abnormal it is and how significantly abnormal it is from the normal. So this is how a normal GCC would look like, and the second one is the abnormal or a glaucomatous GCC would look like, so that we can understand the abnormality. The third thing, which is more recent, is OCTA, that is angiography, but this does not require a dye. Actually, the blood vessels RBC motion itself works as a contrast to delineate the vessels, so it's a very important and simple thing to do, and you can understand the flow, blood flow. What happens in glaucoma is actually loss of superficial vessel density in peripapillary and macular regions, as you see. So a normal OCTA would look like that. You can see the heat map below and the parameters that gives you the angioflow density in each area on the top. If you have a focal defect like an NFL defect inferiorly, as you see there, and you would see an abnormal area where the flow density has reduced. If you see a diffuse defect, it will look like that, where there's a gross absence of choriocapillaries and all the parameters in different areas would be reduced. So this is how it helps us. Having said that, the most important diagnostic parameter in terms of detecting early glaucoma still stays the total or average Rnfl thickness, which carries the most important thing. Now, going through the clinical examples a little, if you look at these nerves, they look largely, cursory view, it looks almost okay. But if you be careful, you see there is a darker area inferiorly there, and you do an OCT, you can see a corresponding thin area there. You do a GCC, and you can see a corresponding change there on the GCC. And this is the perimetry of the patient, and you can see a corresponding field defect. You saw the area inferiorly and a corresponding field defect. So this is a classical example where OCT can help detecting early or pre-perimetric glaucoma. We had seen the example in the previous presentation of pre-perimetric glaucoma, and here you see a patient where so now when we go like that, we have to also look at the downhill side of it. It's this is a patient who was on PG analogs and the nerves are normal. When we look at the perimetry, that is okay. But you can see a lot of abnormal changes onto the OCT. You can see the flag signs as yellow and red in both the discs. But since the clinically patient was normal, we stopped the medication. That answers your question also, sir, in the previous talk. So because this patient was already having the effects of drugs around the eye, and we felt that clinically it is normal, so we stopped the medication. So the skin improved, and this patient was followed up over next 6 years without medication, and you can see the GPA, the patient did well without any medication. So sometimes you have to be careful when you are interpreting these NFL defects. So red on OCT does not always mean disease, so we have to be cautious of the red disease on OCT, always correlate clinically. Second case, this is a case again which shows you a lot of red areas in both the OCT maps, if you see right and left, and the nerves that you see at the bottom are the small discs and more or less looking okay, however sloping rims and all. Be careful about the disc size. When we when we look at the nerves and they are smaller or larger in size, we have to be careful, because when we are comparing the normative database, they do not take into account a very large or a very small disc. So you can see the perimetry of this patient, the fields are absolutely normal. Now why this disparity happens, to understand that, I will take you to the next slide, but we need to understand that small disc can overestimate the damage, and vice versa, large disc can be underestimating the damage. So there you can have the green disease issue where you will have a field defect and not the perimetry defect, the OCT defect. Now, why this happens is because you have a defined calculation circle where the Rnfl defect or Rnfl thickness is measured by the machine. Now, if you have a large disc or a small disc, you see the disc margin is so different. Now, the distance of this calculation circle from the large disc and the small disc is very different. So, as you move away from the optic nerve, the Rnfl gets thinner. So now all your statistical parameters which are comparing with the normal disc would go haywire if the disc size are abnormal. So when we are looking at a smaller or a larger disc, be careful, you cannot rely on OCT alone, you have to keep in mind the visual fields. This is another example of where OCT may not be very useful. It's an advanced glaucoma, you can see both these sides, and you can see most of your black line which tells you Rnfl thickness in a patient's thing is falling in the red area. So this is where the OCT achieves a floor effect, and that is where the OCT may not be very useful. So you need to follow up these patients on perimetry rather than OCT because it gives you a floor effect. So there's a limited role there. So there are certain limitations and artifacts that we need to keep in mind when we look at the OCT. You have to be careful about the scan quality, if there is myopia or poor fixation, media opacities, head tilt, all these things can give artifacts which we need to take care. Now, coming to the scotomas or the perimetry, when do we need it? When you have a clinical suspicion of the disc or glaucoma suspect to establish the diagnosis of glaucoma, patients who are on treatment for glaucoma, and also for progression. So now, how do we look at this printout? We have different zones which tells about the patient and test data. We have reliability indices and foveal thresholds. We have raw data and grayscale, total deviation and pattern deviation plots, global indices, and glaucoma hemifield tests. So these are the zones we need to look at. Well, I will quickly pass through that we have to be sure what is the patient and test data. Now we need to know whether the patient performed well. So first of all, when we do the test, the foveal thresholding has to be done, and we need to look at the reliability indices in terms of the box that you see there and the gaze track. So why foveal threshold is important? Because if your foveal threshold is not matching your visual acuity, like in this patient, you can see the vision is 618 and the foveal threshold is 27. In the below example, the visual acuity is 6.6 and the foveal threshold is 36, which is quite okay. So if it is correlating, then you go ahead with the test. Otherwise, re-foveal threshold and then proceed with the test. That is what your perimetrists need to understand. Second thing is to look at the fixation losses. So during the test, 5% of the stimuli are presented at the blind spot. That is called Heil-Karaku method. So if the patient responds to that, that is considered as false positive responses. And if the false positives are more than 20%, it is considered unreliable. The second way to check that is a two-variable gaze tracking. I'm sure all of you are familiar with that kind of picture that you see on your monitor of the perimeter. So if the corneal reflex is at the center of the pupil, that is a straight gaze, and if it is deviated, then it is taken as a deviation. So that is how it is presented at the bottom of your printout. That is called gaze track monitor. So an up deflection is the movement of the eye away from the fixation target. A small deflection is a small refixation target. And a bottom graph or bottom line tells you a closure or the blink. So we need to look at whether the gaze track is all right. Now this is an excellent gaze track. This is also mostly okay. Patient has done well. In this particular thing, patient was initially shaky, but later on he's done well, so you can accept. But this kind of a gaze track is something that you cannot accept a field for. Another one, the bottom one also, the patient has been closing the eye most of the time. Coming to the false positive responses, I think that is very self-explanatory. Up to 20% is considered acceptable. More than 30%, you get a double cross sign by the machine itself. So if you have a high false positive response, what you see is white scotomas. Okay, and what you see is a high fixation losses. You will see abnormal or positive GHT and abnormally high sensitivity. You will see pattern deviation plot which would be worse than the total deviation plot, which is the other way around most of the time, and mean deviation would be in positive. Generally it is in negative. So it's a supra-threshold kind of a picture, and these are again unreliable tests. False negative also default to 20% and more than 33% are considered abnormal, but this can also happen in advanced glaucoma. So if the patient is not able to respond to the stimuli, machine may take it as a false negative response. So in a very advanced glaucoma, we don't bother about the false negatives and we ignore them and we still take that field. This is a classical example where you see a significant problem in the field, but if you see clinically the disc doesn't look that bad, so you can immediately pick up this is due to high false positives, this is an unreliable field. Another example where you see the disc is normal and the fields are not correlating, that is because there is a high plus power, so that is giving a ring scotoma all around. So rim artifact. So clinical correlation, most important. Despite of everything being all right, there can be a learning curve, patient's first field and the second field. Sometimes the learning curve can be as bad as this patient took 6 fields to reach to the baseline. So unless it matches, you should not be going ahead. And this is another field where anybody can tell me what is abnormal there? Is it a reliable field? The cause for unreliability? False negative is 6%, false positive is 0%. Case tracking is all right. What you see is no blind spot. So it has to be 0, it is 20. Okay, so that means the fixation is bad. So again, unreliable fields. So these are the things we need to look at. Also, while performing the perimetry, the position has to be all right. The lenses should not be decentered, particularly if there is astigmatism. This is a normal patient given a decentered lens, and this is the perimetry report that you get like a biarcuate scotoma. So those are the things that we need to take care. So there are multiple causes to look at the reliability. And then we proceed further about the raw data. Well, you see on the top, the gray scale and the numeric scale, which tells you the exact retinal sensitivity at selected points, and these can be compared amongst the patient's field. So scotoma can be determined by comparing to the surrounding points, and the same thing is presented in the gray scale. Well, these zones we do not give much importance to because we are more interested in deviation plots, which tells us the comparison. These are the symbols that you get. I'm sure all of you are aware, so I'll not go in detail. So total deviation plot and the pattern deviation plot are the two important things that we look at. Now total deviation plot gives you point by point difference from the expected value for the age-related normals. So you have to pay attention to the numbers as well as symbols. The minus means less than what is supposed to be. That is how you see the minus number. When this 7th best point is taken and reduced to look at the focal defects, you get a pattern deviation plot. And again, that is represented in terms of numeric values and the symbols that we need to look at. So this is how a normal field would look like. There can be a generalized depression. There can be a focal localized scotoma, more so related to glaucoma and neuro-ophthalmology. And there can be both generalized as well as local depression. So how do we look at the perimetry reports now, the total and pattern deviation plots? In normal, both the plots would be clean. If you look at the generalized depression, you will see a lot of abnormality on the total deviation plot, but pattern deviation plot would be normal. If you look at the localized depression, both total and pattern deviation plot have similar abnormality, whereas if you have a generalized and local depression plots, generalized and local depression, both the plots would have abnormal points, but the pattern deviation plot would be less abnormal than the total deviation plot. So this is how we look at these deviation plots. Global indices actually give you a numeric summary of the whole field, which tells you how much different it is from a normal patient. So visual field index is something which expresses the visual field status as a percentage of normal age adjusted visual field, and the greater weight is given to the points closer to fixation. This is more useful for glaucoma rather than mean deviation. This gives you in percentage, so higher the percentage, the normal it is. So normal would be 100%, abnormal would be say 1% or 0%. This is less sensitive to the generalized depression. Mean deviation is just a numeric expression of overall deviation of the visual field, so that gives you a number. So if it is positive, as we saw in white scotomas, or falsely high suprathreshold value, you will have plus value. If it is negative, that means a infrathreshold. Pattern standard deviation gives you deviation within the field. That means the pothole. So how much irregularity in a field is there, that is what gives you pattern standard deviation, and that is why it does not have a plus or minus value. It just gives you a value that tells you the abnormality within the field of a patient. Glaucoma hemifield test compares the upper 5 quadrants from the lower 5 quadrants and give you the results in numeric values, whether it is normal, outside normal limits, or in the plain English, whatever it tells you. So all we need to know also is what are the Anderson's criteria. On the pattern deviation plot, if you have 3 or more non-edge points, 1 point P less than 1%, or a cluster with CPST or PSD less than 5% and abnormal GHT, this is what is called Anderson's criteria for glaucoma. on a perimetry. But what we need to understand is only perimetry does not mean anything unless it is clinically correlated. Like here you see a superior notch and an inferior field, biarcuate defect with a superior inferior field defect. Now here if you look at the first field, if you look at it, it fulfills the Anderson's criteria. But unless you look at the optic nerve, you don't know that this is caused by this kind of a choroidal coloboma, which is responsible for the field defect. Similarly, in that field, that is, I think, a repetition, you saw the enlargement of blind spot in a myopia. This is a classical inferior arcuate scotoma, but unless you look at the field, the vein occlusion can also cause this. So basically, what we need to understand is correlation clinically is very, very important. And diagnosis of glaucoma should be based not on a single test, may it be IOP or disc or the perimetry. We need to understand how to interpret structural changes, looking at the clinical disc and the OCT and also the perimetry to understand, although it's a gold standard, but we need to know how to use it before we label a disease to the patient. So clinical correlation is the single most important factor for diagnosis. Thank you. So one quick question for the shift that we can take, if anybody has. Yes. Please do.
Many times when we do the OCT,
Mike, please. Go ahead, we can hear you.
when we do an OCT, we have to edit the disc. In that editing, we just go by the color differential for the total disc and the cup area. However, if you see the cross section, it's not many times aligned with where the cup starts.
So actually, on an OCT, you cannot do that. You can do that in HRT, where you can mark.
Correct.
So OCT does not allow you to change. It can only allow you to
HRT.
change centration. So
Okay.
that is the flaw in HRT. That is why now we hardly use HRT. But the advantage in HRT also is that once you have drawn that contour line, and if you're following up the patient, you can carry forward your contour line.
Correct.
So it can still help you in progression.
Now we've got an OCT where we can edit it and change it.
Okay,
So which line should we take? The color differential or where the slope begins on the section?
So that depends on the clinical evaluation of the disc. So you should have seen the person who is demarcating the line.
I'm
So
demarcating.
when you have evaluated the disc and what you see as a disc margin in a particular disc is what you should mark there. And then on the next exam, you should carry forward that marking and you should not be remarking.
That agreed. But sometimes on the OCT image, like on the color differential, it's showing say a 0.8 cup or a 0.6 cup. And on the OCT, on the gray scale, it's showing, it's not at the edge where it starts going down. Like maybe it's a sloping edge, that's why this differential must have come.
That will always happen.
It'll come. Okay, thank you.
Okay, so now, no, we'll just go have two talks to complete. So what we are going to be talking now is neuro-ophthalmic visual fields. So now we know how to reliably evaluate a particular visual field. Let's see how to do it neurologically. Now, why important aspect of fields in neuro-ophthalmology? Because of the specific anatomy of the visual pathway allows topographic localization of visual fields. Ideal is Goldman kinetic, but what we tend to use is the automatic static perimetry. And as you know rightly, that basically the left part of the visual field stimulates the nasal retina and vice versa. From the retina arise the optic nerves which cross at the chiasma, forming the optic tracts, which carries the same-sided temporal fibers and the cross-nasal fibers to the lateral geniculate nucleus, the optic radiations, and the primal visual cortex. And because of this particular the structure which is there, we are able to have classical visual fields. So from 1 to 8, if you notice, you have the classical visual fields, and we will decide how to evaluate that. Now, unlike what we've done in glaucoma, when you are evaluating neurological fields, always have both the fields in front of you. Especially for students, if they give you one field, ask for the other one because you need to study them bilaterally. So right eye in your right side, left eye to your left. Note the blind spot. It should be temporally in both the cases. You have to look at the gray scale. Unlike glaucoma, where you look at the pattern deviation, here you look at the gray scale. And you ask these powerful questions. 6. Is the field loss? These 6 questions I'll take through, and every time you evaluate them, look at these 6 questions. Is the field loss unilateral or bilateral? Because if it's unilateral, it's anterior to the chiasma, and if bilateral, it goes behind. Like for example, note here, if you're looking at these fields, which is anterior, you will only find one eye involvement. And if you go beyond the chiasma or at it, as you can see here, you will find bilateral visual fields. So look at both the fields. The next question is, does the defect respect the vertical meridian? Because if it does, it's chiasmal or posterior chiasmal. Now look at all these lesions which you can see from 3 to 8, they are respecting the vertical meridian, and therefore if you have something like this, as I said, look at both the fields, you know where to look at. Then, and you see anteriorly, you'll see only the one eye being involved. Now, then the next question is, what is the pattern? It could be a central scotoma, it could be centrocecal, which involves the blind spot, a paracentral, it could be altitudinal, which we just saw respects the horizontal meridian, it could be even acute in neuro-ophthalmology, or hemianopia, where it involves either to the right or the left or the point of fixation, but respects the vertical meridian. It does not cross that. Quadrant anopia is basically involved between your vertical and the horizontal meridians. So once you know the pattern, you need to look whether the defect is bilateral or not. If it is bilateral, then is it homonymous? Now what do you mean by homonymous? This is a temporal field of one eye and the nasal field of the other eye. Because if that is present, we are looking at posterior chiasmal lesions. And then comes, if it is so, which side it is, because it's always to the opposite side of the field defect. Now look at these lesions where you can see these are homonymous lesions, which are all, if you notice, with lesions from 4 to 8. And if you notice, these are left-sided, so obviously the defect is going to be right optic tract or radiations. Then look at this field. This is the left homonymous which you're getting. You will have a defect in the number 4, which is basically incongruous, will have a RAPD and optic atrophy, which are classical features of a lesion like this. This is the optic tract. Now if you have something like this, which is called as pie in the sky, we are looking at a lesion number 5, which is the temporal lobe. And if you have something like that, this is pie in the floor, we are looking at a lesion in the parietal lobe. So again, if you are looking specifically at lesions in the parietal lobe, you look for parietal lobe signs, and temporal lobe, the temporal lobe signs. So this is what will tell you pie in the sky and pie in the floor. Then coming to now what is heteronomous. Now we saw homonymous. Heteronomous means these all had one-sided. You are always seeing same side. But look at here, this is not same side. These are same field, meaning both fields. And that is called bitemporal hemianopia. And when do you get it? Only and only when the chiasma is involved, because here the nasal fibers cross, hence the temporal fields are getting involved. So when you have a bitemporal, there is no other differential but a bitemporal hemianopia due to a chiasmal tumor. So remember that if you get the fields like this, you know where to look at. So once you know the side and the bilaterality, you should find out if the defect is congruous. Now what do you mean by congruous defect? It is, first we'll tell you that it occurs for most posterior lesions. We are ideally looking at an occipital lobe lesion. See, look at this defect. It does not exactly resemble the other eye in terms of shape, extent, and laterality. That's incongruous. Then when you are looking at something like this is perfectly congruous. And this would indicate an occipital lobe problem. So now once we know that, let's look at this cases, a few of them, to detect how to evaluate. 6 important questions: if the field loss unilateral or bilateral, the pattern, does it respect the vertical meridian, if it's bilateral, if it's homonymous, which size it is, and if the defect congruous. So if we have a patient like this, 6-6 vision, 6-9, can anybody tell me? This is only involving one eye, does not cross the meridian. It is a defect which is like an arcuate respecting the horizontal meridian. So where would we expect the problem to be? Anterior to the chiasma. So you have to look at the nerve. So go carefully. This patient has a pale nerve. This is a case of left eye anterior ischemic optic neuropathy. So this is how you detect. And okay, look at the other field. This is a patient who had basically 6-6 vision in the right eye. Everything was normal. Color vision was normal. But in May 2014, she came with a drop of vision. And if you look at the defect now it's showing a centrocecal scotoma, if you can see. So again, you know something, we need to go back and check. We realize there's something involving the blind spot. She actually was case of Takayasu's. This is an anterior ischemic optic neuropathy detected by an RAPD, underwent the IOCO bypass, and the field resolved. So basically, looking at the RAPD for the optic nerve involvement and the field test, we could diagnose the problem. Now let's look at this. What do you think this defect is? Again, when you have a defect like this, what should be your next question? What's the other eye field? Don't evaluate any patient unless you get the other eye field. Now look at the other eye field. Yes, there is a field. So we come to our questions. This is basically central defects, but it's bilateral, it's homonymous. So we are looking at a lesion beyond the chiasma, the same questions. So if you're looking at beyond the chiasma, it's a superior, inferior, right paracentral hemianopic scotoma. When you're looking at a congruous lesion, we're looking at an occipital lobe. Let's understand the occipital lobe representation. There's a calcarine fissure, superior and inferior, and the tip of the occipital lobe. Now, tip of the occipital lobe is known to go and select the central defects. So what we are looking at is at the tip of the occipital lobe. And how did we reach the diagnosis? Only by looking at the two fields, knowing it's bilateral and bilaterally homonymous. So what this patient actually had was a tumor in that. So it's the field test, just looking at the two fields gave us a diagnosis, which is a meningeo of the left occipital lobe. Let's look at another patient, 62-year-old female complaining of visual loss. On hysteria, had undergone multiple because she kept seeing visual loss and they felt nothing was really wrong with her. She was even on glaucoma treatment. But if you look carefully, the disc looked more or less okay. But when we did the visual field, we saw only one eye visual field is there. It is respecting the vertical meridian. But how is the other field normal? So is she actually having an issue? Is she hysterical blindness or organic? No, note carefully. It is respecting the vertical meridian. And if you go closely, you will see there is some sort of an optic atrophy. Now let's look at our description here. When we have something just pre-chiasmatic, which you have something like this, you would have missed actually the peripheral scotoma which occurs in this patient. And hence, we need to look at the chiasma more carefully. This patient actually had a pituitary tumor which was causing it. And this classical field is called as monocular hemianopia of trachea. So instead of treating her as a psychological case, all we need to have to understand the visual fields and get an MRI done. So we were able to salvage her life by getting the surgery done. Lastly, this case, now I guess everybody has quite understood. 52-year-old, 6'6", 6'12", temporal pallor. What is this defect? Yes, this is a bitemporal hemianopia, heteronomous, nothing else, but this patient had a pituitary adenoma. And to just tell you that nowadays in a patient, especially for children who come with craniopharyngioma, may have defects like this, we are not able to do the visual fields, and OCT comes to our rescue. OCT of a macular ganglion cell complex shows binasal thinning, which is very classically corresponding to the temporal field defect. So in cases we are not able to do, you should be able to do this to pick up the problem. So like for example, a patient who has a pituitary adenoma, if you do the OCT, if it's normal, like you see it's normal, and here also if you see the visual field defects can detect or not, yes, if you find these nasal defects, that means you know there is a temporal, there is a nasal compression. You should refer him to the neurologist, correlate it with the tumors. If there is a problem which is compressing, you can go ahead and get the surgery done. And this nasal GCC thinning is helped. But in a patient like this, where there is overall Rnfl thinning, which is significant, and there is a significant loss of the entire macular GCC, we know this is a long-standing compression. You need to go ahead with surgery to at least salvage whatever it is. But in the initial case you saw, if you would have salvaged that and operated earlier, the pituitary adenoma, you can get back the visual fields completely. They reverse. But in a situation like this, this will not reverse completely. So it's always good to detect, do the visual fields, and correlate with your GCC. Thank you. And I will just take the next talk on optic atrophy, how to evaluate.
Mix of cases where you have optic atrophy and look at the various causes. When you see a temporal pallor, how do you evaluate whether it is neurological or glaucoma is something that we would describe with some cases. Yeah, it's showing Jyoti. Yeah.
So it's very convenient that you have actual glaucoma and you have disc elevation and all that. It's easy to diagnose. But what happens is if you have a pale disc, what do you do next? What do you think it could have happened? What would happen future? What do you investigate is what the subsequent presentation I'm going to talk to you will help you through. So you have a situation like this where you either have one or both pale discs. We need to know what to do next. So let's start with two cases to describe. This is a 63-year-old male with blurred vision, known case of hypertensive arthritis spine tuberculosis on AKT for 1.5 years, underwent spine surgery thrice. The ocular examination showed less vision by 624 on N24, color vision defective, amsuglated relative scotoma. So this is the case one, which you can see. You can see a presence of pale disc, which is here. Now let's simultaneously look at one more case. So this is case 2, a 50-year-old female with sequential loss of vision. First in the right eye, about 1.5 years ago, and then for left eye only 4 months ago. Diagnosed as optic neuritis, was receiving IVMP, was a known case of hypertensive and diabetic mellitus. The IVMP was given only on the basis of this optic neuritis, which showed the presence of one periventricular lesion that you can see, and therefore he was being treated. Now, if you see, the vision in the right eye was significantly low because of the already present optic atrophy of 2/60, and left eye was 6/24. Pupils were sluggish in both the eyes, and you see the classical discs. We can see, as I said, when you are evaluating a disc, always do first under magnification, and secondly, use a red free. Red free will tell you really the pale looks much pale and the red looks redder. So that helps you differentiate, knowing that the left eye is more than right eye. But note, the amount of pallor does not tell you about the visual acuity. Patient can have a pale disc but a normal vision. It just tells you whether there is pallor or not, that's all. It doesn't tell you its correlation with the vision. Yes, so when we have a typical disc appearance, let's check how to detect the etiology. Optic atrophy, you could have any of these changes: temporal, cupping, arterial attenuation, bow tie, and peripapillary gliosis. So if you have temporal defect, that is a pallor set in, it could be at a toxic or nutritional neuropathy or an optic neuritis. If there's presence of cupping, you look at an ischemic cause, a toxic cause, or a compressive optic neuropathy. Arterial attenuation, look at ischemia. You also have to look out features like RP-related problems and LHON, which is obviously a poor prognosis, but remember, none of them is pathognomic. These are just guidelines of you to discuss what it could be, so you can evaluate and investigate accordingly. A bow tie classically has a contralateral optic tract lesion, and it also can involve the optic chiasma. And peripapillary gliosis, we are looking at post-papilloedema. So to elaborate what I just said, you could either have a bow tie atrophy. What do you mean by bow tie atrophy? You can see the superior and inferior part of the disc is pink. It's only the middle part which is pale. That is called as a bow tie atrophy. And when you have something like this, in the left eye, you have to look at something else. So if it's a left eye, you can see there is a right tract lesion. As you can see, right homonymous defect. This is because of craniopharyngioma. It is a left optic tract. So this is what will tell you corresponding to your bow tie atrophy. The other aspect is secondary optic atrophy, where you're looking at the muddiness around your optic nerve heads, indicating this is a post-papilloedema. And an important aspect that if you are looking at an optic atrophy, always look at beyond the disc. Do not forget to see the retina. Like this patient has an entire laser done around PRP, and because of that, there's a consecutive visual optic atrophy that has set in. Now, once we have known that there's an optic atrophy, we have evaluated the disc. Now, let's look at the visual fields and see how you can evaluate. So, when you have an optic atrophy, you can do it in 3 ways. You could either have a central or a centrocecal scotoma. You could have an altitudinal or arcuate or a hemianopia. So, central centrocecal scotoma, something like this. You are looking at a toxic or a nutritional cause. In one eye, you are looking at an optic neuritis. On the other hand, it's an altitudinal and arcuate. You're looking at an ischemia cause. You could also have glaucoma, and it could be an optic neuritis. Hemianopia, as I said earlier, it is involving one half of the visual field, which is respecting the vertical meridian. It could be neurological, that is compressive optic neuropathy. So as explained earlier, if it's heteronomous, then you're looking at a chiasmal lesion. If it's homonymous, you're looking at an optic tract lesion. Again, nothing pathognomic. You should know if it is so, what are you likely thinking of, so that you can investigate on those lines, that is. So now coming back to our cases, which we started, this is a case 1 who was a patient with hypertension on treatment for AKT. You look at this field. So as you can see, there's a temporal defect. Now you need to go beyond the disc and see, look at the macula more closely. What would you order when you have a thing? A visual field. And when you order a visual field, you see bicentral scotomas, but they are neither respecting the vertical meridian, not horizontal. Hence, you have to go anteriorly, look at your disc, which we saw something at the macula. This is a classical bullseye maculopathy. When we did the FFA, we realized that this patient actually had this kind of defect, and this is toxic optic neuropathy. Because the patient was on AKT, it was an ethambutol toxicity. Coming to our case 2, where we saw something like this, it was a total dyspallor. This patient was being treated for optic neuritis, but what was more important is carefully note the arterial attenuation. That should not be missed. And as I said, if there's arterial attenuation, you should look carefully for ischemic causes. Get a BP done anytime, every time in OPD. It was 180, 120. So this patient had this particular periventricular lesion, only one lesion, unlikely to be because of MS, for which he was treated. Note that when I said about MS, you should have these overt lesions perpendicular to only the periventricular area, which was not in this case. This is just one random one, which is a lacunar infarct. So the actual problem is not related to the MRI, so not to be treated as optic neuritis, but a basic bilateral optic neuropathy. Status was ischemia. So he needed to just be treated for his hypertension. Then case 3, which was a 29-year-old gentleman wearing spectacles since 5 years, having blurring of vision. Everything looked all right. Had a little, disc had a little issue when I saw carefully. As you can see, there's a little pallor. Again, when you have anything like this with the issue, with the disc, do a visual field analysis, which is a must. And on doing visual field analysis, we got a defect, which is like this. So again, coming to our 6 questions, this defect is only in one eye, so you are going to be expecting something anterior. This is a left eye superonasal central defect, as you can see here. This central defect is actually related to, we have to go back and look at your optic nerve. And if you see carefully, this is related to a nerve fiber layer defect that you can see. So basically, this is the case of left inferotemporal nerve fiber layer defect, suggestive of glaucoma and probably NTG. So now Sushma will just tell you something more about NTG, and she'll take the last case.
Yeah, so, okay. So again, once again, coming back to the same point, clinical disc evaluation takes the most important thing. There many a times you can see the nerve fiber layer defects lying there, and the patients have been diagnosed as temporal pallor or inferior rim pallor and being treated like that. You cannot have a wedge-shaped Nfl defect in a ischemia or anterior ischemic optic neuropathy or optic neuritis. So that has to be evaluated carefully, because in this particular patient, it's a young patient, the pressures were normal, it is hard to pick up, but this is a classical sign which can tell you that this is glaucoma or a one-time damage due to glaucoma. That is also a possibility where you can have the normal pressure. So you need to evaluate on the basis of that. So every pallor is not always neurological. There can be glaucoma issue. This is one of the overlap case that I will show you. This is a 67-year-old male. Came with sudden diminution of vision in right eye since one day, and that's how came to Jyoti. On examination, vision was right eye was 3/60 and left eye was anyway blind. So he was having ophthalmoparesis in the right eye, and they were suggestive of Tolosa-Hunt syndrome. MRI showed Tolosa-Hunt syndrome. So they were wondering why he has a sudden loss in the vision, because 3/60 vision. But when we take the history, this was a known case of glaucoma. Was on AGM in the right eye and having undergone glaucoma surgery in the left eye in 2007. When you look at carefully gonioscopy and the anterior segment, there were YAG PIs there. Patient had narrow angles, was a case of angle closure glaucoma. And the previous day vision recorded was 636, and now he came with 3/60. So since the optometrist saw the vision and sent that sudden loss of vision, there was left eye RAPD. That was because the left eye was blind, and this is how the nerve looked like. So if you look at the fields here, this is the 24-2 advanced damage. You do a 10-2, and this is how it is. So actually this is advanced glaucoma, and in such patients, when you're evaluating vision, particularly when there are fixation involved, unless your optometrist is having enough patience to allow patient to read from the residual temporal field, they would not be able to assess the visual acuity consistently as the same. And in angle closure type of glaucoma, when they have sudden increase in the pressure, they can actually present like discs with the anterior ischemic optic neuropathy. They look more pale than having cups because there is a sudden increase in the pressure. That can also happen in patients with neovascular glaucoma, that the patients who experience a sudden increase in the pressure. And also we need to understand that there is a possibility of coexisting of certain diseases where the neurological and glaucoma cases can coexist, and we need to take care of both. So to end, I think we need to correlate clinically, take a proper history, connect the dots, and then make the diagnosis before we decide treating a patient and look only at one aspect. Thank you so much. You've been a wonderful audience. We could rush through all the presentations. I think we have 5 minutes where we can have questions before we start the next one.
She, 1 minute, she had a question which we had just called.
Yeah, can you give her the mic, please? I will explain it, sir.
Thank you very much for these wonderful presentations. Now it's on the differential diagnosis, differentiating the optic disc edema.
Yeah.
For the optic neuritis, when you were talking about the MOG and the aquaporin 4,
Yeah.
could you please differentiate further? Because I know there are two different entities, you know, beyond just looking at the optic disc, because they are not the same from what I understand. Are there ways in which to further differentiate them, because we know they have different outcomes
Yes.
at the end of the day?
History, very important. In NMO, you have intractable hiccup, and vomiting is very commonly seen in patients with NMO, which you don't see in patients with MOG. MOG patients can have presence of disc hemorrhage. So if you have a disc hemorrhage, very commonly. Secondly, they respond wonderfully to steroids. That's why initially the chronic relapsing inflammatory optic neuropathy was considered as now as MOG. So when you treat them with steroids, they'll immediately respond in a day or two, which will neither happen with optic neuritis or MS, or it will happen with NMO. So that's the reason how you differentiate. Secondly, the MRI scan is very, very specific. In case of MOG, you'll have the perineural sheath as well as a fat which gets enhanced in patients, unlike the NMO. And in case of NMO, you have longer segments. In MOG, you'll have short segments, and sometimes, yes, not spines, along the optic nerve head. And you may have chiasmal involvement, very commonly in terms of MOG, with bilateral involvement.
Thank you very much.
Thank you.
So just to answer your question, false positive means when the patient has not seen the stimulus but pressed the button, which can happen because of the sound effect or the consistent effect that they keep pressing the buttons. False negative means patient has seen the stimulus but not pressed the button. But how the machine knows it? That because at the same location, patient would have responded to a lower stimuli, and when you present a higher stimuli at the same point or the same stimuli, patient does not respond. So that is why it comes as false negative. And that's why we ignore false negatives when there is advanced damage, because there is a significant depression.
How upper limit we can take it as a normal, not normal, means we should use...
Sir, 20% and 33%, as I said. Less than 20% is what it should be. More than 33%, you have to do the fields again in terms of false negative. Similar is for false positive.
You can take it as a...
Yeah, less than 20% is acceptable. Yes. Thank you so much.
Could you tell us something about the post-vaccination optic neuropathy and its treatment?
Post-vaccination
Because we
optic
have
neuropathy.
seen, yeah,
Okay, Jyoti,
we have seen some
that's
cases.
for you.
Sorry, yes?
Post-vaccination optic neuropathy. That's the last one, because we have to give this next session.
Yes, so post-vaccination optic neuritis is very commonly in children. They come with sudden loss of vision, but within 3 days they respond. So this kind of post-infectious, post-vaccination is something which comes as bilateral, it's anterior, and disappears with very good outcome, and mostly seen in children. That's one
And the
aspect of...
treatment?
I'm sorry, no treatment,
no
it just gets
treatment.
treated on its own.
Yeah, but I've seen in adults also, like unilateral.
Yes, if you are able to tell that it's unilateral, then yes. If you are able to rule out all the other causes, as I said, a normal MRI scan is important because you need to see that it's not. Then a course of steroids can be done to prevent it from recurring. Yes. Yeah. Oh, yes, yes, yes. Oh, मेरा वो video session चल रहा है.